This is Selma Schimmel, and this is Unique and Unmistakable Amsterdam. The cultural and commercial capital of the Netherlands is used to being the center of attention, and this year is no exception as it hosts the European Cancer Congress 2013. This is a multidisciplinary cancer congress sponsored by ECHO, the European Cancer Organization, ESMO, the European Society for Medical Oncology, and ESTRO, the European Society for Therapeutic Radiology and Oncology. Bringing together the most imaginative and innovative minds and researchers from across the continent and around the world to engage global stakeholders, coordinate a unified oncology community, and speak with one voice. Vital Options Advocacy in Action is here to do the same, bringing together influential leaders of the cancer advocacy community for a three-part advocate forum. This is our fourth European Advocacy in Action, and we are so proud to be in Amsterdam, grateful to be partnering with ESMO and ECHO, and honored to bring it to you. What do we as advocates need from healthcare professionals to help ensure greater compliance and adherence?
For example, one thing we found out that low-grade side effects largely affect adherence. So people, because they have a low-grade diarrhea or something like that, they leave out therapy consciously because they want to feel well. And that connected to the fact that if the doctor is approachable, if he addresses side effects, if he addresses the issue of adherence, drives adherence, basically shows we probably need to think about what are the risk groups in patients that are probably not adherent, probably with low-grade side effects that don't need direct treatment, or they might not kill the patient because it's just grade 1, but in the long run it will annoy him so much that he will probably not take the treatment. And if there's no discussion with the doctor about the consequences of not taking treatment, he might just decide, okay, I'm not taking it, the consequences to my cancer will probably not be difficult. So it's a lot about dialogue.
Why do you always say dialogue with the doctor when there are nurses there as well?
It's a very valid point. I'm probably saying that because in CML, patients are mostly treated out as an outpatient. So yes, in some countries, exactly, like in Germany, unfortunately, I would say, patients don't have very much talk to the carers and to nurses.
But that's, again, this cultural diversity.
It is.
So that I think one really has to see where one is living and who is your contact person or persons.
Yes.
Germany is a very special area because of the nurses. I don't consider that the sort of... We regret. Yeah. And so I think we really have to use both healthcare professionals, including community nurses, because most patients with oral therapies are not being treated in a hospital situation, and so they need a multifactorial catch group, if you want to call that, if they have a problem, to say, my doctor, I can't talk with him, I don't really like talking with him, so let me call someone who I can talk with, and that would be a nurse or somebody with whom they can say, I don't feel well with this drug, because there are any number of possibilities why they're not going to take it, including costs. They say a medication for kidney cell carcinoma is too expensive, I'll take it every second day.
I can probably come in on that, because we have a global meeting of patient advocates where usually we have patient advocates from about 50, 60 countries present. And we always invite the nurses to present on side effects and on adherence and on complementary therapy, because we understand the nurses are the ones that have the best expertise on that. So maybe that reassures you about the fact that the nurses play a very important role, and they have insights that doctors very often don't have, because in Germany they have about 9.1 minutes per patient, while the nurses sometimes have much more time with the patient.
What is really important is to get out the message that actually educating the patient is essential for its compliance. And I think that if the doctor has the time, that's good. If the nurse has the time, that's good. But we have to have a mechanism by which the patient has access to information. I think it's also very important to have a printed material that the patient will take out with him, because always, usually they will forget most of what they discussed with you during their visit. But I would strongly suggest that kind of data should be spread, and doctors, nurses informed about the consequences of non-adherence. And I would say, a doctor with experience will know how to target directly the toxicity that is most disturbing for the patient. As you said, diarrhea grade 1 is something that is really miserable. So I think this is key to ensure compliance, adherence.
Having spoken for how many years have I been doing this? 15 years, and interviewing people, and I always thought I really understood about these issues of adherence and compliance until I became in a situation where I had to take my oral therapy. And everything I thought I understood, I really didn't understand until I was the one that had to open up that bottle 2 times a day. And let me tell you, it's a lot easier to go to the doctor and have the oncology nurse wire me up and stick that needle and give me my infusion. That was so much easier than having to go home and be responsible and deal with myriad issues that I really wasn't prepared for. And I am very educated as a patient and an advocate. And so my understanding now of the issues is profoundly different than what I thought I understood.
That's a very powerful statement, and actually, you have to juggle with this information. Sometimes we do choose IV therapy instead of oral therapy because of fear of compliance. But obviously the attraction of the oral therapy, it's that it makes the patient much less dependent on visiting the institution.
Selma, I think also what you were saying, Alexander, about talking to the patients, very often, and you may confirm this, the healthcare professionals use too complicated explanations, and the written material is not understandable. It's not in the language that the patients understand. It's not in the print size that the patients can read. And so I think there are many more issues that we do have to think about.
And one of the things is, I know that it's common to tell patients, this is so much easier.
Yeah,
and I think patients really need to be prepared for, it's easy in the sense that you have the convenience of taking therapy at home, but the onus and the responsibility becomes so much greater on the patient, and I think we want to be prepared going into it for all the possible side effects that you may not feel the first week, but may be cumulative, especially if you're going to be on an oral therapy for months on end. And, you kind of get battle fatigue.
Yes. And I think what we can't forget, or who we shouldn't forget, are the caregivers who are at home for people who are not well and have to have help to take their medications as well, with the same information, that there's really a complete flow through all of those who are affected from the cancer and the therapy.
Thank you, Dr. Enyu, Jan Geisler, and Anita Margulis for being part of this interactive panel.
Welcome. Thank you.
Thank you.